This is the October 15th Virtual Collaboration Forum. Thank you so much for taking the time to join us this morning. We really appreciate it. As always, my name is Carrie McNabb. I am a staff member of the Alberta College of Family Physicians and work on the Collaborative Mentorship Network. I'm going to take you through some housekeeping this morning, and then I'm going to hand it over to our wonderful presenters. First and foremost, we would like to start off this meeting with a land acknowledgement. We would like to recognize that we are webcasting from and to many different parts of Alberta today. The province of Alberta is located on Treaty 6, Treaty 7, and Treaty 8 territory and is a traditional meeting ground and home for many Indigenous peoples. So what are we going to talk about today? So we had talked about and gotten recommendations from our committee and members from the last session. We thought it'd be really great to focus on clinical pearls in a virtual world. And so we have two presentations today, one focused on trauma-informed care and the other on virtual pain assessment. So at the end of this session, these are a couple of the learning objectives that we've set for ourselves this morning. And a disclosure, I would like to introduce our medical lead, Dr. Kathy Scrimshaw.
Hi. My disclosure is I am a part-time employee of the Alberta College of Family Physicians. Otherwise, no conflicts or financial interests.
Thank you very much, Kathy. And again, in disclosure for myself, my only disclosure is that I am a paid employee of the Alberta College of Family Physicians. Again, disclosure of financial support for this program. This program only receives financial and in-kind support from the Alberta College of Family Physicians. We are also the recent recipients of a Health Canada contribution through the Substance Use and Addictions Program. These virtual collaboration forums are also certified. So you get 1 credit per hour for every meeting that you attend. You will see a little attendance survey link in the chat log. So please make sure you fill those out during every meeting so that we can log your attendance and do your certificates of attendance at the end of the year. Thank you. Event evaluations. These are a very important part of us determining if we're doing the right thing, the best thing that we can for our members. It's also extremely important when it comes to getting continued funding, making sure we meet all our funding requirements. Kathy, did you want to speak to evaluations briefly?
Yeah, it just would be great at the end of this event if you can fill out the evaluation. It is part of the ongoing contribution requirements. So it's really important to us. It should, take less than 5 minutes, and we really do use those evaluations to evaluate what we're doing and to make sure we're presenting things that are valuable. So thank you.
Excellent. Thank you so much, Kathy. So our agenda for this morning. So our first speaker for this morning is Dr. Harbir Gill. His topic is the role of trauma in chronic pain and addiction. So I'm going to hand it over to him right quickly here. And then as soon as he's done his topic, he'll do a little bit of Q&A. And then we'll start our second presentation, which is with Dr. Lori Montgomery on virtual pain assessments. And then we'll wrap up the session. So without further ado, I will hand over the presentation to Dr. Gill. Thank you for joining us, Dr. Gill.
Oh, it is lovely to be with you all. Thank you for having me. So I'm gonna, covering all of trauma in 15 minutes is tough. So we'll move fast, but we'll try to move with grace as well. So I just wanted to introduce myself. So I am a family physician. I've got a certificate of added competence in addiction medicine, and over the years, I continue to have a small family practice, but over the years, I've sort of narrowed my practice to sort of high complexity addiction, mental health, and chronic pain, or any mix therein. I've done extensive training in a lot of areas, and trauma therapy is the relevant one for today through various modalities like EMDR and imaginal nurturing and other such things, ego state. I have pretty much worked in every field in outside of obstetrics of of family medicine. And it's given me a very nice bird's eye view. And also was involved in management in Alberta Health Services back when I was a hospitalist, which actually was really helpful for understanding the role of mental health in pretty much all of our challenging systemic and local issues. Mental health is always there in some way, shape, or form. So my disclosure mainly is that I'm the founder and physician at the Northeast Addiction and Mental Health Center for Holistic Recovery, NAM. And so that's the organization, nonprofit organization that I've founded, and our mission is holistic recovery for all, and we're going full speed ahead. So that is, and my other disclosure, I think, is that I got a $5,000 research grant from the Canadian Family Physicians of Canada to study mental health in 18 to 25-year-olds. So that's the other disclosure. So let's go get to the meat of it. If you can go to the next slide. And a bit about that quote at the bottom. People ask me, like, how can you work with all these folks, with all these issues? And it's just absolute pleasure to regularly, not occasionally, but regularly see transformation. And it is possible, and it's possible in these patients. The current real problem, really, one of the reasons why I founded NOM was because our current model really disintegrates in many ways. And I'm not going to get into all the ways, but we disintegrate patients. That's what we're going to talk about today. We disintegrate families and support systems, care plans, team members, everything crisis and recovery. Even evidence-based practices are disintegrated, meaning they're not integrated. And you lose a lot of synergy when you don't integrate. And I think all of you are aware of how our system manages chronic pain separately from mental health, separately from addiction. And that is entirely part of the problem. And, oh, brilliant, Carrie. So I put an elephant there because this is the elephant in the room, which is repetitive negative thinking, histories of trauma, and intergenerational cycles. This is not rocket science. We all know this. It's just, what do you do about it? And that was the thing that really puzzled me on my journey. Is all of these patients, some patients staying in Peter Lloyd. We had one patient stay there for 4 years, and it was all mental health related. And she had been intubated for breath holding over 100 times from a code, but it was all actually very much trauma related. And so these issues are concurrent disorders are the norm. They are not the exception. So therefore, everything needs to be concurrent, capable. And my journey into all of this really began with addiction and learning about how do you treat addiction? How do people get better from addiction? And the answer is addiction treatment comes down to 3 things, really. It comes down to stress, managing stress, avoiding and reducing negative stress, recognizing it when it happens, and getting it down right quick before it gets past the threshold of which bad things just automatically tend to happen. And so people in addiction, people in recovery from addiction have really had to figure it out, either that or death. And many do die, as we all know. So and then generalizing all of this, that's really where my interest in trauma kind of arose. So next, if you want to just pop up the next thing. Yeah, family medicine, there we go. So this is my primary research interest. Is holistic recovery for all is not like a Dr. Gill thing, Harbir Gill thing. It's not a NOM thing. It's actually an everyone thing. And actually the revolution will be when primary care physicians take the lead in holistically addressing these issues, because they're all very interconnected, and trauma is kind of one of the biggest parts that interconnects them. So let's go to the next slide. I'm sure the slide has been sort of sent at some point, or this is not new to some of you, but I actually really like this. I like patients don't see us because they're in pain. Let's be honest. Patients do not see us because they're in pain. Patients see us because they're suffering. They think that's pain. It may well be pain, but it's always multiplied by something we call resistance or non-acceptance. And so pain, we do what we can, right? We diagnose, we treat, we, ablate and do all those things that I won't get into today. I think actually we're pretty good at that. I think we do a generally decent job of the pain. The suffering, though, relates to the resistance. And if any of you have patients who are on oxy and don't want to leave oxy, even for morphine, they don't want to switch to Dilaudid, they don't want to switch to morphine, because they are deriving emotional and benefit that's related to that suffering. Oxy is the worst of them because it has such a strong emotional benefit. So, if you wonder why transitions to Suboxone don't work as easily and seamlessly, they work, but not easily in patients on oxy, that's why. I like to look at this equation and think, okay, well, if someone's resisting the pain, what is it? Perhaps they've been kind of messed up their whole life, and now they have pain, and they're stuck in a victim mode. And there's nothing that worsens pain than the pity party that comes with pain. And so that oftentimes arrests any productive adaptive behaviors. So I look at this equation with a lot of hope, because you can multiply pain up for sure, but you can also multiply it down a lot. And so we'll talk a little bit about how trauma fits into that. So let's go to the next slide. There's lots of studies on trauma and pain. I've listed some of them here. The one that I'll mention is the concurrence of PTSD and chronic pain varies from 0 to 57%. Why is that range there? Because it really depends on how you define trauma. If you define trauma as clinically PTSD, you must understand that PTSD only lasts for a period of time. When it's mixed in with lots of other PTSD, it kind of just becomes kind of normal. And so then those symptoms which we use to define PTSD become lost. My clinical experience is that trauma, if you go looking, and if patients are honest and you build that relationship, it's there virtually most of the time. So that's why that big range is there. And that's probably the biggest takeaway from today is my suggestion, maybe consider going looking. You'll be amazed what you find. And any of you who have patients who are older on sleeping pills, go and have a long chat with them. Book off an hour and explore their history. And you'll find lots of stuff that may surprise you. So I just listed a couple of studies there for you to look at, just identifying that people with chronic pain tend to have traumatic things in them. Let's go to the next slide. ACEs. Love the ACEs. ACEs is not a new thing. Some of you may be aware of this questionnaire. It's amazing how correlated addiction and outcomes and lots of stuff is with ACEs. This is very, very commonly put in the literature, and there's lots of studies on this. So I'm just going to read some statistics. If you have an ACE score of 4 or more, and you can read those on the side there, 14 times higher chance of a suicide attempt, 5 times higher, 4.5 times higher likelihood to develop depression, 11 times higher risk of intravenous drug abuse. This matters, right? And I want to illustrate to you why this stuff matters. If you go to the next slide. And by the way, I do encourage all of you to apply the ACE questionnaire to yourself. And it will probably help you understand. One of the best ways to understand trauma, we all got it. One of the trauma therapists that taught me, she had a really great saying, which is all good therapists have a therapist. And there's a good reason for that. So the best way to learn about trauma is to address it in yourself, where it is there. So here's the traumatic perspective. And I basically just took a little slide from, or I took a sentence or a paragraph from the internet. And really trauma is an error of learning. That's really fundamentally what it is. And so I illustrated it here. You know, on the left-hand panel, you have the healthy. In the middle, same paragraph, but a couple of the letters are substituted. It's intelligible. You can kind of make it out, right? You can kind of guesstimate, estimate what it's saying. But the more substitutions there are, the more fundamental substitutions there are, the more vowels that go, the more sort of the common things like the S's and the T's, right? No one really cares about the Z's, right? If you don't know your Z's, that's okay. But if your A always equals an E, that's a problem. And so it's really hard to discern. And the funny thing is, if you try to tell someone, oh, figure out what their issue is, why do you always make spelling mistakes? Like, come on, you're never going to figure it out because these errors are fundamental. It's like someone you always trusted told you that 1 + 1 always equals 3. And you believed them until the age of 12, that's what you were taught. And then suddenly that wasn't true. And so if we go to the next slide, here's what that means. So imagine what life would be like if everyone you ever trusted and told you that those in power always abuse it. What would life look like? Imagine if you learned through betrayal that women could not be trusted. How would that impact your relationships in life? Imagine you learned the only way you could have love is by pleasing people. Where would you fit in? Imagine if you learned early on that from everyone you ever trusted, that you're fundamentally just a bad person. You deserve badness in your life. How would this shift your perspective? This is what errors in learning look like. Trauma therapy is finding where the errors in learning and correcting them. So unless you understand someone's, like, you know, someone will continue. This is very common, domestic violence, very common. One abusive relationship right into another, fourth time, fifth time, 10th time. So at some point you got to say there's something patterned here. There's something learned where being beaten is comfortable at some level. So if we go to the next slide, this is a surprising slide for many of you, because this is, and the psychologists understand this very well, the medical community does not. And it's really fundamental to how we categorize trauma. So we're all about PTSD. If you read the DSM-5, the PTSD criteria are all about activation. Bad thing happens, results in activation, avoidance of that trigger that causes activation. I think we all get that. So I characterize that as the flood damage after the rainstorm. So you have a river and it gets flooded, and then there's damage after the flood. But obviously some people flood a lot easier than others. And so that is this second category, where children who've been undervalued, who've been sort of parentified, have kind of not been able to trust the adults, not felt love. What happens to them is they have lower riverbanks. They flood a lot easier from any stressor. So this is your patients with chronic pain. This is your fibromyalgia patients. Fibromyalgia is a particular one that's almost always correlated with trauma. And the thing is if your stressor is pain, then they're flooding all the time. I can't blame them for wanting to alter their mood with oxy. Really kind of makes sense, actually. So looking at trauma as not just the presence of bad things, but the absence of enough nurturance is crucial. This is what we call complex PTSD, and people with chronic pain tend to have it. Let's go to the next slide. Dissociation and trauma. One tidbit that I learned was dissociation is the rule. Somatization, everyone does it. Everyone has the capacity to somatize. And whereas in medical school, I was taught that, and most of you were probably taught that some people somatize. Everyone somatizes. If you are giving a public speech and you have butterflies in your belly, that's somatization. Everyone does it, and it presents in funny ways. Dissociation, this neuroscience of this is very well understood. When you get traumatized, part of you gets left behind in the past, reliving that again and again and again. And then you learn to avoid those things that take you back to that. That's really what PTSD is. The more PTSD you have, the more of these emotional personalities that come up. A and P means apparently normal person, that's the front. And then the emotional personalities are kind of the back end. And then, you know, when it gets really severe, you get multiple personalities and things. That's a little bit extreme. Usually torture and things creates that. A lot of the patients who have chronic pain either dissociate with substances, or they dissociate on their own, or they dissociate with both. And that complicates managing their care, because they are oftentimes actually unaware. The human capacity to repress memories is vast, and all your patients do it. Some of you probably do it. We all do it, actually. It's a very common thing. And that's another reason that you can't quite trust the ACE questionnaire. A lot of people, they say, no, no, no. And then later on, yeah, I was molested. It comes out. Let's go to the next slide. Solutions. No easy solutions. So I just wrote this journey. Healing is a journey with many paths and no shortcuts. But it has 4 components. You got to do it all with every issue each time. And that's awareness, leads to compassion, leads to forgiveness, leads to acceptance. Everyone jumps to acceptance, and if you haven't done the work in the middle, you have not gotten there. You're not even aware. So our job is to initiate the journey. And depending on our ability and our training and whatnot, we can go a bit further with that. But everybody can raise awareness. Let's go to the next slide. One of the things I love about trauma is that because of how our brain processes, the neuroscience of this is so old now. It's like it's so entrenched and validated. Once you deal with the trauma, it's dealt with. If you've dealt with a mom issue, and that particular memory is neutralized, it will never come back to haunt you again. It is definitive, much like a surgical problem or much like a UTI. I love treating UTIs. UTIs is great. There's the funnest thing to treat ever. You just give antibiotics, it's satisfying, they feel better, you feel better. Hopefully it doesn't come back and life goes on. Trauma is like that, actually. And so don't be discouraged. People can get better. When you find those key memories that like the molests and all those things, and they're usually consolidated to one memory, and you can find it and clear it, profound. They like come in with a phobia and they leave your office without a phobia. It's tremendous. It's absolutely wonderful. Difficult symptoms, somatization, oftentimes. A lot of health anxiety is oftentimes related to traumatization. And then best thing of all, we got good evidence-based treatments. Next slide. And so I'm not going to go through each of these, but we do have lots of treatment options, and EMDR is the one that I use a lot of because I find it works very powerfully. I can talk more about it. Let's go to the next slide. Truth is, there are treatment options. There's also evidence supporting those treatment options. You can review the literature. Next slide. Next slide. So what can you do? Raise your awareness, please. Screen your patients with the ACE questionnaire. We can do something about this. There's some books I suggest you read or get your patients to read. The Courage to Feel, awesome book. Talks about both kinds of trauma, and it's all tied to feelings. Getting Past the Past is by Shapiro, EMDR creator, amazing book. And The Body Keeps the Score. If you do nothing else with these patients who have a high ACE score, here's a book. Or even if they don't have a high score, here's a book. Every patient with chronic pain can benefit from learning about feelings. Explore and develop local resources. Consider getting trained. Advocate in your PCN for not just any therapist, but trauma-trained therapists. because it's actually an added specialty. Not every psychologist does not treat trauma. That's part of the problem. It's seen as this thing that only a few kind of strange people do. Everyone can do it. You do got to deal with your own issues, though, if you're going to do trauma therapy. So if people are comfortable with the label of addiction, NA, Narcotics Anonymous, AA, these are trauma treatment protocols. They have all the components. And then other spiritual traditions, people are, like, process trauma in the context of faith, context of other things, like indigenous people need their indigenous sort of things. Nothing more valuable to an indigenous young person with pain and trauma than an elder, and asking them, hey, you have an elder you can kind of hang out with? And some of them will say yes. And coming from a doctor, it'll be like, oh, that old person in my life, yeah, there's value to that? Yes, there is, because that person can help me get over trauma. Let's go to the next slide. And just some references for you to look at. And then I apologize, I did go over my time. I know there's less time for questions. My sincerest apologies. I tried to compress a lot of this. I got to acknowledge Monica Soho, who helped me craft the presentation and did a robust review of literature for me. And if you have questions, please email me. Happy to always talk about this stuff.
Thank you so much, Harbir. We are so grateful for you taking the time this morning to join us. You know, we do have a couple of minutes if we do have maybe one question before you've got to pop off. We've got some people on the call. The chat log has been a little quiet this morning. Kathy, if I may pick on you, do you have one question for Harbir before he goes off this morning?
I guess I have the question of one of the reports we had in our own South Zone when we were looking at ACE scores was a reluctance of physicians to open that door because lack of access to trauma-informed care or trauma-informed counseling. How would you answer that question of, I don't want to open that door because I don't have the skill? What would you say to family doctors who are in their offices with 10 or 15-minute appointments? How would they handle that?
Good question. Yeah, a lot of folks are worried about opening the door. Honestly, the doors are usually open. So first of all, like they're just not telling you about it. Second thing is that you are, if someone like looks really severely traumatized, you just ask them. You don't have to do an ACE questionnaire. I mean, it doesn't matter if their trauma is like sexual or whatever. If they're like, yeah, I'm really traumatized, that's enough. You don't need to do the ACE score. Then you just need to do the motivational interviewing and help them connect to the resources, right? But if someone's like, a lot of chronic pain, no apparent kind of thing, and they seem relatively well resourced, you're not going to destabilize anybody a lot by administering the ACE questionnaire. The thing about trauma is you kind of, all roads begin with awareness. And if people are unaware, and a lot of people with chronic pain are very much unaware of the link between their issues and their pain, and if no one assesses it, then it's not a complete history. You don't have all the information. And so you got to kind of go there, but you don't have to necessarily administer the full questionnaire if you're worried about destabilization. You can just ask them. And if they say no, then administer the questionnaire. And it's unlikely to cause any significant degree of destabilization. But just one other comment on that. I would encourage all of you to really consider blocking off a half hour or 45 minutes at some point with your difficult patients and just sit down and have a chat with them, right? Like you can't fit this into a 15-minute slot all the time. You can when it's like kind of on autopilot there, but to actually get aware of people's issues, it really is helpful to, you know, sit down with somebody and be like, hey, what's going on in your life, and going beyond the usual social history of do you smoke, do you drink, but like, hey, how's your relationship with your parents? Who's in your inner circle? Oh, you know, I notice your dad's not there. Is there a certain issue? And then all the estrangement and the issues will start coming out a little. And I'll tell you this, the risk of not doing this So lots of people talk about what will happen if I open the box. The risk of not opening the box is a lot of death. And I'll just put some stats out there for you all. 50 men every week suicide in Canada. 30 women suicide every week in Canada. The cost of this is not, for every person that you cause to suicide by asking them the ACE questionnaire, which will probably be 0, because most people don't suicide because a box is opened. That's not, that might be the straw that broke the camel's back, but that was gonna happen anyways. It's the cost of not being aware and offering people, and family doctors are fundamentally the front line and are the best positioned. If you are, I'm always happy to come back and teach some grounding skills and things to make people more comfortable in sort of opening a bit of the box, just to be aware of it. And that's a little bit beyond the scope of what I was asked to present on today. Does that answer the question?
Yeah, I think it does. I know I have a colleague in Lethbridge that uses an ACE questionnaire with every new patient she has. And it has been extremely helpful for her in dealing with all sorts of chronic illness, let alone issues in substance use or chronic pain. So I think that showed me that it was very useful in a regular family doc's practice.
Just one last comment that I'll share. Patients sometimes view family doctors as part of their family. As a result, they actually are ashamed to tell you about their molestation or this and that. So they may not always tell you. And that's kind of partially because they view family doctors as not therapists, which I think is an important paradigm that needs shifting, because I think family doctors are family doctors. We're primary care, we do everything. And that should include some of that. And so they may not always tell you, but like I said, it's virtually most of the time it's there. And you can do something about it.
Thank you so much, Dr. Gill. Again, we appreciate you taking the time to join us this morning and share these, and also providing your email if there's any follow-up questions. Anyone, if you think of questions after the session, which is what I typically tend to do, you can always send us an email or drop us a note, and we can reach back to Dr. Gill and ask him for his advice on those things if they come to us after the fact. But that is the time that we have for this topic this morning, and I'm going to move forward into our second presentation of the morning, which is going to be from Dr. Lori Montgomery. Again, thank you, Dr. Gill. We very much appreciate it, and welcome to Dr. Lori Montgomery.
Thank you. So I'm talking about virtual physical exam. In contrast to Dr. Gill, I am not in any sense an expert in this topic, other than I do it all the time. So I think that's probably why I was asked to talk about this, because it was a topic that you all identified as something that you wanted to hear about. And like lots of you, I think, my practice shifted very abruptly in early March and became almost 100% virtual. So even as we've started to open up, I'm seeing patients in person at the Chronic Pain Center, but I would say still probably about 80% of my days are virtual visits. So all of my new appointments with patients are all by telephone and Zoom. And my follow-ups we do by telephone or by Zoom if there's physical exam required. So I do a lot of this, and I've kind of been forced to learn a little bit of the background about it. Next slide. So just in terms of disclosures, I do have a small grant from the Hotchkiss Brain Institute to do a pilot clinical study of a medication, and other income coming from the national and provincial colleges just for committee work, but no industry connections. So I'm going to really try at a very, very high level over the next few minutes, just talk about when we do a virtual exam, why it's important, some of the evidence that exists for some of the techniques that I'm talking about, and just in concrete terms, how do you actually do this? Next slide. So, sorry, I can't mute that. So basically, you know, we probably all learned as part of our residency training that most of what you need to know is found in the history, and that is absolutely the case with chronic pain histories. So, so most of what you are going to, what's going to be important about diagnosis and about crafting a treatment plan, you're probably going to get from your history. You really can do a fairly focused physical exam, even with somebody with quite diffuse chronic pain, to focus on the things that are going to change your management. Physical exam, though, is something you can't skip, and it is important, even if you're very clear on the diagnosis. It's important for rapport building. It's important for the patient to understand that you understand the pathophysiology, the pain, and you're making a recommendation that's based on their particular specific situation. And I also find it quite helpful to get a sense of what parts of a treatment plan the patient needs more than others. It changes your perspective very much when you're able to actually see the patient and see how they present. Next slide. So what is the evidence for this? So virtual telemedicine physical exams are not new, although they are relatively new in Canada. So for many years, we've actually kind of lagged behind the rest of the world in terms of virtual physical exam and just virtual care. That, of course, changed really quickly in March. There is systematic review level evidence that doing a virtual physical exam of the low back is acceptable to patients. They feel validated, they feel like they've had a good exam, and that the results that you get, the decisions that you make are comparable to an in-person exam. There is some evidence of utility in all kinds of contexts. So the virtual exams have been looked at in all kinds of different contexts, that both within and outside of chronic pain, but I've just listed some of the contexts here that are particularly relevant to chronic pain. The one thing about those studies is that they don't always look at patient outcomes. They look at things like satisfaction and follow-up and adherence, things like that, not necessarily improvement in pain or outcomes like that. A lot of the individual exam techniques have actually in the literature been compared to your in-person exam and validated. So there actually is a fair bit of evidence behind a lot of it. Next slide. So some of the things, just practically speaking, that are important if you're going to be doing a virtual physical exam, it is helpful if the patient can test out their equipment ahead of time and give them an idea that you're going to be wanting to see them when they're sitting, see them when they're standing, plan for a camera angle that would allow for that. A lot of people, I find, use their phones for a Zoom physical exam, so that's okay if there's some place that they can prop up their phone. Depending on what part of the body you want to examine, or what kind of an exam you want to do, they might need to wear shorts or wear a tank top, or have pen and paper handy that they can write on. One thing that's important is that in this virtual age, the patient, you could be reaching the patient anywhere at all. You need to make sure that you know where they are physically. So are you physically at home in case something happens during the exam and I need to call for help? Are you at home alone? If I need to send an ambulance, God forbid, where are you physically? We talk about the risks of a virtual exam in the sense that, you know, Zoom can be hacked. Your personal information isn't as secure as it would be if we were in the room together. Assure the patient I am in a space where nobody else can see you on the screen, and, you know, make sure that you are in a place where you're comfortable with whoever's in the room while we go through this. And be aware that some of the physical exam techniques that you do maybe have a risk of falling. So it's helpful if there is somebody else in the house with them, if they're comfortable with that person being around for the exam, or you may have to just skip some of the things that you, like a gait assessment that you might do if you really think that they're a fall risk. Next slide. So just listed off typically the parts of the physical exam when it comes to a pain exam. And I'm going to highlight some of the sort of interesting elements of each of these things. Next slide. One thing that often gets ignored with virtual exams is vital signs. When somebody's in the clinic, I always check blood pressure and weight, because those are things that are affected very much by the medications that I'm using in pain. Remember that those are things that you can still check at home. So many patients have a blood pressure cuff at home that they can check for you. And many people have a scale that they can just weigh themselves, and you can make a note of. Next slide. So there's lots of things in terms of inspection. On the left side there, I've kind of listed off the things that are probably most obvious that you can check on webcam. On the right side, some of the things that you might not necessarily think about, but to me are probably the most important parts of a pain physical exam. How stable are they really? If it is safe to check gait, what do they look like when they get up and move around? What does their posture look like? Do they have a really chin forward posture? Are they holding one shoulder in elevation? Does their jaw sit slightly deviated to one side? Things like that. You can get a really good sense of muscle guarding, and when you watch how somebody moves, how they get up out of a chair, how they lift their arms. When we're talking about potentially involving somebody in a rehab program, if I'm thinking about, do I want this patient to see our physiotherapist, for example, I really need to get a sense of how easily do they move, how afraid are they of movement. When I try to cue them to move, can they move easily? Can they follow cueing? Those kinds of things are important. Next slide. So palpation, you can do actually, because you can actually cue the patient to do a lot of those techniques. Sometimes if they have a family member or a friend there, you can get them to help you with some of these things. But I find that I can get a lot by just asking a patient to palpate a particular area. If you know your anatomy well and you can cue them to where you want them to palpate, you can actually get a good sense. With my headache patients, I often will get them to sort of feel along the muscles of the back of your neck, slide your fingers up your neck until you can feel the base of your skull, slide your fingers up maybe 2 or 3 centimeters from the base of your skull there, and poke around those muscles there and see if it's tender. And if it is tender, if it's painful, does that pain radiate anywhere? And often people with a lot of tension in the occipitalis muscle will get some irritation of the occipital nerve, and they'll get pain radiating over the front of their head into their eye when they poke around those muscles there. So that's a useful thing that you can cue the patient to do. So there's all kinds of those. Next slide. There's some other examples here of, there's an article that I've linked to at the end on exam of the foot and ankle, and some fairly specific areas that you can get the patient to palpate on the webcam and actually map out for you where the maximal pain is, whether it radiates, and you can get a sense of some of the pathologies of pain based on that. Next slide. So range of motion obviously is one that you can check very easily on webcam, just cueing patients. Often I need to make sure that I'm set up in a place where I can actually show the movement, because sometimes just verbally asking a patient to do something doesn't necessarily, they often need you to say, you know, do this, do this, do this. There is actually a fair bit of evidence for a web-based goniometer, which I don't use a goniometer in the office, so that's not something I'm going to use online either. But if it is something that you use in your practice, there is a web-based version of that that you can use by telemedicine. Next slide. Think about the vascular component of your exam. You definitely can get a sense of perfusion by looking, just examining color. You can get patients to test capillary refill. You just get them to bring their body part up to the webcam and test and see if it fills. Sometimes you can get patients to check their own pulses and let you know what they feel like. Next slide. Strength is one that you have to get a bit creative sometimes, but things like if the patient can walk on tiptoes, they have at least 4 to 5 strength. You can get them to squat, walk on their heels, jump on one leg if it's safe, if their balance is good, and you can get a decent sense of lower body strength. If you have a friend or a family member there, they can check against resistance and tell you if it's different from side to side. One thing when you're looking at when you're sort of in terms of special tests is arm circles. So if you get somebody to roll their arms around like this, if one side is weaker, it'll be still and the other side will sort of satellite around it. And really just, you know, if you're just checking like this, arms out, hold your hands there for a few seconds. If they can hold it for more than 5 seconds, they at least have anti-gravity 4 to 5 strength in the limb. Next slide. There's a lot that you can do with the neurologic exam. So of course, mental status, affect, you can comment on. You can observe a tremor. You can look at cerebellar signs. You can get a patient, if they have an area of numbness, you can get them to map out, show me exactly what that area, run your finger up your face here and show me, tell me when you get to a point where that numbness starts, and you can start to map it out. You can get them to use an ice cube to check temperature sensation. Definitely you can check allodynia. If you just run your hand lightly over your jaw like this, is it uncomfortable? Proprioception you can do if you have a family member or a friend there to check. If somebody's really dizzy and unstable, you probably don't want to check a Romberg unless you've got somebody there to keep an eye on them. But I will get a friend or a family member to, let's say, you know, stretch out the patient's leg, grab hold of their toe like this towards the face is up, away from the face is down, have the patient look away from the camera and the assistant, when I go like this, go up, when I go like this, go down, and get the patient to check to see whether they can identify that. Some things that you obviously can't check. Apparently there is also a device you can get the patient to use online to do fundoscopy, but that's a little bit beyond where I would go. Next slide. Cranial nerves, you can very easily check on webcam. There's a few little modifications you need to make. So with cranial nerve 2, one of the things that I did not know until I started doing lots of virtual exams is that red saturation is cranial nerve 2. So if you just find an item that is red, hold this up to the screen, cover one eye, what do you see? Cover one eye, what do you see? If there's a problem with cranial nerve 2, they'll see it, the red, differently from eye to eye. The other thing, I'm going to show you the NIH stroke cards, and that's another thing that you can use to check cranial nerve 2 by virtual exam. And then 3, 4, and 6, you can get them to bring the camera up right close to their eye, close their eyes, squeeze them tight for a second, and then open up, and you can have a look at the pupils and see if they respond. The others, you can probably easily see how you would check those by a webcam. Next slide. So the NIH stroke cards, you can just download and print off and have them, that you just hold them up to the screen. Get the patient to cover one eye. What do you see? And how many people do you see in that photo? If they have to move their head in order to tell you that there's 3 people in that photo, then they may have a visual field defect. Next slide. You can do the same thing with the sentences on the NIH stroke cards. So, you know, cover one eye, can you read the whole sentence? Next slide. You can get them to do the line bisection test, which is just draw a line and then mark the halfway point in that line. And you can see on the right side there what happens if you have a unilateral spatial neglect. Next slide. You can do a MOCA. You do have to prepare ahead of time, so the patient needs to have pen and paper. You need to have some of the images printed out that you can hold up to the camera and get them to copy or get them to identify. If you really want the full MOCA, and you can, with the validated scale, you do need to get them to print out the visual spatial test ahead of time, and you just have them hold it up to the screen and point for you, you know, A, 2, B, 3, show you what they're going to do. But really, if you can do the rest of the MOCA and get a decent sense of their cognitive status without getting them to do trails. Next slide. So there are lots of the special tests that you can modify, but I'll just kind of go through a couple of them just to give you a sense. So next slide. So the article that I talked about around foot and ankle exam, this is obviously a super exaggerated image of what happens with the Thompson test if you're looking for an Achilles rupture. But you can position the legs so that the patient can themselves sort of squeeze the calf and see if you get movement in the foot. Next slide. Sperling's test, actually, it turns out the literature would suggest does not require axial compression to be valid. So you actually don't need to be putting that compression on the top of the head. You can just get them to extend, side bend, and rotate. So you just have to give them that instruction to look up, bend to the side, and look up at the ceiling. And then if they get pain down the arm, that suggests radicular signs. The other thing that happens sometimes with that test, if they localize pain very specifically to a very focal spot just off the midline, it's potentially a sign of facet arthropathy. It's not a well-validated sign of facet arthropathy, but it is a suggestion that you might want to look at the facets and see if they're potentially involved. Most of the time, what happens when you do that is people will talk about stretching pain on the other side, on the opposite side. Next slide. And then, of course, things like this, you can look for hypermobility, and which is something that you see quite commonly in people with chronic widespread pain. Next slide. Just wanted to highlight in my desperate searching back in March to try to figure out how to do this, some of the things that I found that were helpful. So there's this Mayo Clinic Proceedings series, really good article on the general MSK exam for pain. It's quite comprehensive, and there's links within the article to videos that will actually show you how to do the special tests and the low back exam and a whole bunch of techniques that you can use. The foot and ankle article, it's beautiful. It's got all kinds of photos, and it's actually got a physical exam checklist that you can go through for foot and ankle problems. But it's also, you can easily extrapolate that, and you can see how you would use that physical exam for the shoulder or the hand or whatever part of the body you're specifically looking at. And then if you're interested in the neurologic exam, not just the cranial nerve exam, she goes through the whole neurologic exam. Dr. Jennifer Robley, who's a neurologist in the US, did this Facebook Live session early in the pandemic, and they've got it on the American Headache Society website, so you can link to that and look at her neurologic exam. So those are some of the things that I've found that have made my life easier. And I would be happy to answer questions if I know the answer.
Thank you so much, Lori. We truly appreciate it. These resources are excellent. We'll make sure to share the slide deck. And we do have a few minutes left if there's any questions for Lori.
Lori, I don't have a question, as Kathy Scrimshaw, while people are thinking, but one of the things that I have started doing is I've had home care take their phone for exam on some of my chronic patients that are receiving home care, particularly on the Piikani First Nation, just because they've sort of don't want any of us coming out onto the reserve because of the pandemic. And I found that super helpful, is we just schedule it with home care, and then they have assisted in that physical exam, especially with my older patients. And I don't know if anyone on the call has been doing anything like that, but I've been just accessing a home care. We book a time, and it's worked out really, really well, because sometimes the technology has been difficult with some of my patients, but I just throw that out there. But really appreciate that, the cranial nerve exam. So that we recently had a case where my patient said my eye looked funny, and she sent me a picture, and it was a cranial nerve 3 palsy with the pupil spared related to diabetes, but it was really interesting to get that picture. I went, oh my God, this is very abnormal. So thank you.
Yeah, well, and that's one of the things that I've learned over the last few months is initially I thought the physical exam was going to be the challenging part. And there's so much that you can do by webcam that, yeah, definitely it's the technology that's the limiting factor if people don't have that.
Yeah, we do have a couple of minutes left. So if there's anyone on the call that does have a question at this point in time, feel free to unmute yourself and ask it directly to Lori if you feel comfortable.
Good morning, this is Tracy with Help Alberta's Pain. My question is about the patients who are technologically challenged. We found that there was a lot of fear of patients going into these appointments because they weren't sure what to expect. So what we did to help our patients was set up a pretend appointment where we used Zoom, what their doctor was using, and give them a chance to work through it with somebody coaching them. How do you handle that when your patients aren't comfortable with the technology?
Oh, yeah, that's a good point. So our staff usually will call them ahead of time and give them a bit of a heads up that this is potentially coming, and and we have a bit of an instruction sheet that they can look up some tips online. Zoom actually has a tutorial for people that they can go to look at to see how it works. But usually what I do is I start my visits with them on the phone. So rather than just sending them a Zoom link and expecting them to navigate that, I start with them on the phone and do as much of the history as I can on the phone. And then when we get to the Zoom piece, I can actually talk them through it and explain to them how it works and you know, why we're doing it, and actually, you know, say to them, okay, click the blue button, and then I'm going to read you the number, and you put the number in there. So, so we just go through it step by step on the phone. So I've found that most people are okay with that process. They're a little less comfortable with the idea of just getting a link that they're going to click on and show up for their appointment. It's a little intimidating.
Great question, Tracy. Thank you for that. I think that's something very common. Lori, did you say that you had a kind of patient info sheet that you share with your patients?
There's one that AHS, yeah, it's just a standard AHS form that it just has instructions for how to access the Zoom tutorials and some of the security information around Zoom. Yeah, I can send it and we can post it on the forum.
Yeah, that would be great, actually. I don't know if that's something that's being used broadly or not, or if anyone knows. Okay, excellent. I did see a comment in the chat saying the link to the evaluation is having some trouble. So thank you so much for pointing that out. We can resend the evaluation link to everyone and make sure that's working. Anyways, look at us on time. I think we are ready to wrap if there's no final comments. Kathy, anything from you?
No, thank everyone for coming, and our next collaboration forum, we will be talking about some community approaches to substance use disorder, and Esther Tailfeathers from Kainai Blood Tribe, and actually Claudette Chase from Sioux Lookout are going to talk about some of the approaches they've taken in their communities. So it should be an interesting session. Just want to make sure people know about it. So thank you very much for coming.
Excellent. Thank you so much, everybody. That's it. That's all. And thank you for joining us this morning.